All right, everyone, get ready, because today we're taking a deep dive into a pretty specialized topic, congenital breast deformities.
Definitely specialized. And we're going to be focusing on the surgical aspect.
Exactly. Using a chapter from a medical textbook to guide us through all the ins and outs.
Sounds good to me. So where should we start?
Well, I think it's always best to start with the basics.
Okay, back to the beginning.
Yep. Breast embryology, development, and anatomy.
The foundation.
Precisely. We got to understand the normal development before we can even begin to grasp the deformities, right?
Absolutely. That's a great point. And it's not just about understanding the physical aspects either.
Oh, you're so right. The psychological impact of these anomalies can be huge, especially for younger patients.
Yeah, imagine going through puberty with a breast deformity. Talk about tough.
Absolutely. So pre-surgical counseling is super important, and there's a lot to cover.
Like what?
Well, first off, timing is key. Finding that sweet spot between addressing the deformity and allowing for natural breast development.
Yeah, we don't want to interrupt the normal growth process.
Exactly. But there's a whole conversation about staged reconstructions.
And the challenges of achieving perfect symmetry.
Oh, and let's not forget about scarring. That's a big one.
Definitely got to be upfront about that.
And then we also need to talk about future pregnancies and the possibility of breastfeeding.
Right, because those can be impacted too.
And setting realistic expectations about how both normal and reconstructed breasts change over time.
It's all about informed decision-making.
Couldn't agree more. Now, before we even think about surgery, a thorough patient history is crucial.
Like, what kind of things are we looking for?
Well, any previous breast surgeries for starters?
Okay, makes sense.
What else? Family history of breast or skin cancers? That's another factor.
Right, those can definitely influence our surgical approach.
And then, of course, referrals and testing.
Bringing in the experts.
Exactly. Geneticists, radiologists, oncologists, got to have a team approach.
Couldn't agree more. Teamwork makes the dream work, right?
For sure. Okay, so let's jump into the different types of congenital abnormalities, shall we?
Yeah. Let's do it. What's first on the list?
How about Poland syndrome?
Okay, so Poland syndrome, it's a spectrum of findings. It can be pretty variable.
In what way?
Well, you might see anything from just a mild underdevelopment of the breast, hypoplasia,
Okay.
to a complete absence of breast tissue areola, even the subcutaneous fat.
Wow, so it can be pretty dramatic.
It can. And it's not just the breast tissue itself either.
What else is involved?
Often we see rib deformities, sometimes even missing ribs altogether.
No kidding. That's wild.
And then there's the pectoralis muscles that can be affected too, particularly the sternocostal head of the pectoralis major.
Right, that makes sense.
Right.
And what about the axillary fold?
Ah, yes, the axillary fold. It can be absent or webbed in some cases.
So it really is a multifaceted presentation.
It is. And it can even extend beyond the chest in some cases.
Really? Like what?
Well, some individuals with Poland syndrome also have brachysyndactyly.
Brachysyndactyly, meaning?
Shortening or webbing of the fingers, basically.
Wow, so it's a syndrome that can involve multiple body systems.
It can. Now, in terms of treatment, are we essentially borrowing techniques from post-oncologic breast reconstruction?
That's a great question. I would think there would be some overlap.
There is, to a certain extent. But there are also some unique considerations with Poland syndrome.
Like what?
Well, for example, where exactly do we position the nipple areola complex?
Right, because that can be tricky.
And how much existing breast parenchyma do we have to work with?
That's a good point.
What does the contralateral breast look like?
Right, because we want to try and achieve some semblance of symmetry.
Exactly. And then we also have to think about how these breasts will change over time with age and potential pregnancies.
Lots to think about.
It's a complex puzzle, but a fascinating one for sure.
I agree. Okay, let's move on to another interesting set of conditions, polythelia and polymastia.
Ah, yes, the supernumerary nipples and accessory breasts.
Now, I remember learning about the Kojava classification system for these back in med school.
Yes, the Kojava classification, very handy for categorizing these conditions.
So let's start with polythelia, the presence of extra nipples.
It's actually the most common congenital breast anomaly we see in pediatrics.
Really? I had no idea.
Yep, it's more common than you might think. Affects something like 0.2 to 5.6% of the population.
Wow, that's a lot higher than I would have guessed. And it affects males and females equally.
You got it. It's not just a female thing.
Interesting. And typically these extra nipples are located along the milk line, right?
Exactly. Usually unilateral and most frequently inferior to the normal breast.
So there's little remnants of the mammary ridge that fail to regress during development.
Precisely. Now, how aggressively do we treat polythelia?
That's a good question. Is it something that always needs to be surgically removed?
Not necessarily. Oftentimes it's completely asymptomatic and observation is sufficient.
Okay.
However, we do have to keep in mind that these accessory nipples, they can develop the same conditions as normal nipples.
Like what?
Well, things like melanocytic nevin or even malignancy.
Oh, wow. So it's not just a cosmetic issue.
It's not. We have to think about the potential for future problems.
It sounds like it's a judgment call based on the individual patient.
It is. Taking into account their clinical presentation, their concerns, and the potential for future issues.
And sometimes a simple excision is all that's needed, right?
Often, yes. Especially if we're trying to avoid a wider excision later on after puberty.
Makes sense. Okay, let's talk about polymastia now, which involves actual accessory breast tissue.
So not just extra nipples, but actual glandular tissue.
Exactly. How common is that?
Not as common as polythelia, but still present at birth in about 1% of the population.
Okay, and is there a hereditary component to this as well?
There can be. Just like with polythelia, we see a mix of sporadic and hereditary cases.
So are there any red flags that suggest a familial link?
Well, familial polymastia has been linked to some concerning things like chromosomal abnormalities and urogenital malignancies.
Oh, wow. So it's not something to be taken lightly.
Definitely not. And we also need to be aware of the potential association with thoracic and renal anomalies.
So a good workup is essential.
Absolutely.
Mm-hmm.
Especially in children who are presenting with other congenital anomalies, a renal ultrasound is a good idea.
So these accessory breasts, they're not just a cosmetic issue.
They're not. They behave just like any other breast tissue.
Meaning?
They can experience painful swelling during pregnancy, they can develop fibroadenomas, and they can even become malignant.
So surgical excision is sometimes warranted.
Absolutely. It might be indicated for medical reasons, but psychological and cosmetic factors also play a role.
And I imagine timing is important here too.
You're right. We typically wait until breast development is complete before we consider surgery.
So we're dealing with a more stable situation.
Exactly. Now, in terms of surgical options, sometimes a direct excision is straightforward.
Okay.
For smaller, fatty breasts, liposuction might be a good choice.
And what about those cases where the accessory breast is right up against the normal breast tissue?
Those can be tricky. We might use tissue-sparing techniques in those situations.
Like what specifically?
Well, potentially involving skin de-epithelialization and accessory nipple excision.
Sounds complex.
It can be. And of course, we always have to be mindful of potential complications.
Gotcha.
Well, things like seroma formation, incomplete excision damage to the intercostal brachial nerves, painful scarring, even the risks of overaggressive resection.
Definitely things we don't want to see.
Nope, not at all. So it's crucial to have a thorough discussion with the patient about these potential complications beforehand.
Absolutely. Okay, let's move on to another set of terms. Athelia, amastia, and amasia.
All right, so these are the ones that often trip people up.
Yeah, they do sound a bit intimidating.
They do, but they're actually not too bad once you break them down.
Okay, so let's break them down. What's athelia?
Athelia is simply the complete absence of a nipple.
Okay.
Amastia is the absence of both breast tissue and the nipple areola complex.
So the whole shebang is missing.
Exactly. And then amasia is when the glandular breast tissue is missing, but the nipple areola complex is still present.
Got it. So basically different degrees of absence.
Exactly. Now, these conditions are pretty rare.
They are.
But when they do occur, particularly if they're bilateral, we need to think about potential associated congenital anomalies.
Like what specifically?
Well, Poland's syndrome, which we've already discussed, can sometimes present with these.
Okay.
And then there's choanal atresia athelia syndrome, Al-Avodira's Rothschild syndrome, and even scalp ear nipple syndrome, also known as SEN syndrome.
Oh, that's a lot of syndromes.
It is, so we need to be thorough in our evaluation.
What kind of workup would you typically do for these patients?
Well, a careful examination of the palate, checking the upper extremities, looking for dermoid cysts, and being on the lookout for any signs of ectodermal dysplasia.
So we're looking for clues that might suggest a broader developmental issue.
Exactly. And there's also a potential genetic component to consider.
Oh, right. I forgot about that.
We do see familial cases sometimes, often with an autosomal dominant inheritance pattern.
But as of now, we haven't identified a specific gene responsible.
Not yet, but research is ongoing.
So lots to learn still.
Always. Okay, so let's talk about treatment options for athelia amastia and amasia.
All right. What are our surgical options?
Well, for athelia, we primarily focus on reconstructing the nipple areola complex.
Using what kind of techniques?
Things like small tissue flaps tattooing or skin grafts.
And for amastia and amasia, where the actual breast mound is missing.
In those cases, we'll borrow techniques from post-oncologic breast reconstruction.
But I imagine there are special considerations here, too.
There are. We need to be aware of potential abnormalities in the blood supply, for example.
Right, it makes sense.
And we have to carefully reconstruct the inframammary fold.
And precisely position the NAC.
You got it. And timing is also critical.
Is it ever possible to start reconstruction before the patient is fully mature?
Sometimes we might initiate tissue expansion before full maturity in some cases,
Okay,
but we typically delay the final reconstruction until after the breasts have fully developed.
makes sense. Okay, so moving on to hypoplasia and micromastia, essentially a deficiency of breast tissue.
All right, so if we're dealing with the typically developing adolescent, reassurance and observation are often enough.
Just let nature take its course.
Exactly. But if we see signs of abnormal puberty, then a more thorough medical workup is necessary.
What kind of conditions should we be considering in those cases?
Well, the differential is pretty broad, actually. We need to think about things like hypothyroidism, ovarian failure, androgen excess connective tissue disorders, mitral valve prolapse, even previous chest radiation.
So lots of potential culprits.
There are. It highlights the importance of a detailed medical history.
Absolutely. Now, breast asymmetry is something we see all the time. How do we approach that?
Well, first off, it's important to reassure patients that asymmetry often improves naturally as the breasts mature.
So sometimes no intervention is needed.
Exactly. However, about 25% of adult women will retain some degree of asymmetry.
So how do we decide when intervention is warranted?
Well, a thorough history and physical exam are key. We want to know about any prepubertal breast injuries, like trauma burns, infections, previous surgeries. We also carefully examine the thorax and spine.
Looking for any underlying skeletal issues.
Precisely. And if surgery is indicated, our goal is to optimize the hypoplastic breast first.
And then consider symmetrizing the other side if necessary.
Exactly. Now, I know we're not going to delve into juvenile breast hypertrophy today,
We'll save that for another deep dive.
but let's touch on some other abnormalities of the nipple and areola complex.
Yes, go.
We'll skip over the extremely rare ones like cleft nipple and intra-areolar polythelia for now.
Okay.
But nipple hypertrophy is worth mentioning. It's relatively common, especially in certain ethnic populations, and we have various reduction techniques at our disposal.
Okay, and what about congenital nipple inversion?
Ah, yes. That can be a tricky one.
It can. What causes that to happen?
It's caused by tethering of the lactiferous ducts, basically pulling the nipple inward.
And how common is it?
It occurs in about 2% to 10% of the population.
Okay, and what kind of problems can this cause?
Well, it can increase the risk of recurrent infections,
Yeah, makes sense.
and it can make breastfeeding difficult or even impossible.
So it's not just a cosmetic issue.
Definitely not. And importantly, we always need to rule out malignancy or infection as the underlying cause.
So how do we manage congenital nipple inversion?
Well, for mild cases, non-surgical options like suction or retraction devices might be sufficient. But for more severe cases, surgery is often the best approach.
Are there any specific surgical techniques that stand out as being superior?
Honestly, no single technique reigns supreme.
So the judgment call.
It is. We might use techniques like circumferential areolar edge, tightening dermal flaps, or even division of the fibrous bands that are causing the tethering.
Sounds like a delicate procedure.
It can be, and we always need to be mindful of potential complications.
Like?
Well, alterations in nipple sensation, breastfeeding difficulties, injuries to the lactiferous ducts, nipple necrosis, and even recurrence.
Yikes, lots to consider.
There is. Okay, so let's shift gears now and talk about abnormalities in breast shape.
Sounds good.
This is where we encounter some really unique presentations.
Like what?
Well, tuberous breast deformity is a great example.
Tuberous breast. I'm not familiar with that one.
It's basically a breast that's hypoplastic, meaning it lacks proper development, but it still functions normally.
Okay.
The key features are a small base diameter, limited height herniated breast tissue, pushing into the areola, a tight skin envelope, and an abnormally positioned inframammary fold.
So it would be pretty noticeable.
It can be. It can affect one or both breasts, often asymmetrically, and there's a whole spectrum of severity.
What causes this to happen?
Well, basically, there's not enough skin and fascial support around the areola, creating a sort of constriction ring due to thickened fascia in the lower part of the breast.
So instead of developing radially outward, the breast tissue herniates toward the nipple areola complex.
Exactly. And as a result, the areola itself extends.
Interesting.
Yeah.
How do we classify tuberous breast deformity?
Well, there are various classification systems out there, but the one that's gained the most traction is the MIRA classification. It helps us categorize the severity based on factors like the degree of constriction, the position of the inframammary fold, and the adequacy of the skin envelope.
So how do we approach treating tuberous breast deformity?
It all starts with a thorough analysis of each patient's unique anatomy.
We're looking at.
Skin deficiency nipple position, the distance between the nipple and the inframammary fold, the degree of perioral or fascial constriction, the breast footprint, the patient's desired breast size, and whether an implant can even be accommodated. We also assess the areola.
So a lot to consider.
Definitely, it's a highly individualized approach.
What surgical techniques are typically used?
Well, we have a variety of tools in our arsenal. We might use tissue expansion and staged reconstruction radial scoring of the gland redistribution of the glandular tissue mastopexy, or even resection of some tissue. Lipofilling or fat grafting can be useful, and in some cases, we might opt for a dual-plane musculocutaneous flap.
Wow, that's quite the toolbox.
It is, and of course, we can also reduce and tighten the areola.
So really tailoring the approach to the individual patient.
Absolutely. Okay, before we wrap up this part of our deep dive, there's one more breast shape abnormality we should discuss: synostia.
Synostia, what is that?
Synostia is an extremely rare condition where the breasts essentially merge in the middle.
Like they're connected.
Exactly, forming a web or bridge of tissue between them.
And what causes that?
It occurs because the intermammary sulcus, that little dip between the breasts, is absent.
So it's a very distinct presentation.
It is, and while the exact cause is still somewhat of a mystery, it's thought to be related to abnormal proliferation of the mammary ridge during development.
So is there any way to surgically correct this?
There are a few techniques that have been proposed.
Like what?
Well, one involves excising the web of tissue and using skin flaps to fill the resulting defect. Another approach focuses on redraping the breast tissue over the sternum, using sutures sometimes in conjunction with liposuction to remove excess fat.
So basically trying to restore a more natural separation between the breasts.
Exactly. The goal is to create a more defined intermammary sulcus and improve the overall aesthetic appearance.
Well, we've covered an incredible amount of ground in this first part of our deep dive.
We have. What are some key takeaways you hope our listeners are walking away with so far?
Well, I think the most important takeaway is the incredible diversity of these conditions. We've gone from relatively minor anomalies like polythelia all the way to complex deformities like tuberous breast.
And each one demands a tailored approach.
Absolutely. There's no one-size-fits-all solution here.
Exactly. We have to consider the individual needs and goals of each patient, taking into account their anatomy, age, overall health, and personal desires.
So it's about finding the perfect fit for each patient.
Precisely. And I also want to emphasize that while these conditions can be challenging, effective treatments are available. We've made significant strides in surgical techniques, and with ongoing research and innovation, the future looks even brighter.
That's a great message of hope. Now, before we jump into the next part of our deep dive, let's pause for a moment and let all this information sink in.
It's a lot to process, I know. But remember, we're not alone in this. Incredible resources are available for both patients and medical professionals. So I encourage everyone to seek out information, support, and guidance when needed.
Excellent point. Knowledge is power, especially when it comes to making informed decisions and advocating for ourselves or our patients.
It really is amazing how far we've come, in understanding and treating these conditions, but there's always more to learn, right?
Always. It feels like we're just scratching the surface sometimes.
I know what you mean. Like when it comes to the genetics behind these deformities, there's so much we still don't know.
Exactly.
Yeah.
Imagine if we could pinpoint the specific genes involved.
Oh, man, the possibilities.
Early diagnosis could be revolutionized.
For sure. And maybe even gene therapies to correct these issues before they even have a chance to develop.
Wow, that'd be incredible.
Game changer for sure. And then there's regenerative medicine.
Oh, yeah, that's a whole other exciting frontier.
The potential there is mind-blowing. Using stem cells to grow new tissues.
Do you think we could one day create fully functional breast tissue for patients with amastia or amasia?
I think it's definitely within the realm of possibility.
Wow, that would be amazing.
It would. And it's not just science fiction either. This stuff is happening right now.
It's so cool to be a part of this field at such an exciting time.
I know, right? Every day there's something new to learn.
Speaking of learning, it's one thing to talk about the technical aspects, but I'm always drawn to the personal stories.
Me too. It's those individual stories that really bring it home.
Do you have any particularly memorable cases that have stuck with you over the years?
Oh, there are so many. Let me see. One that comes to mind is a young woman with severe tuberous breast deformity.
Oh.
She had been so self-conscious her whole life, avoiding social situations, struggling with body image issues.
I can only imagine.
We worked together to plan out a multi-stage reconstruction, and the transformation was just incredible.
Was it just the physical change that was so profound?
It was more than that. It was about restoring her confidence, helping her feel comfortable in her own skin.
Wow. That's what it's all about, isn't it?
It is making a real difference in people's lives.
It's not just fixing a physical problem, it's about improving their overall well-being.
You said it. And it's important to remember that these surgeries, as amazing as they can be, they do come with risks and challenges.
Of course, no surgery is without risk.
Exactly. We always need to be aware of potential complications like infection, bleeding, poor wound, healing, the possibility of needing revision procedures down the line.
And even when things go smoothly, there are still those nuanced challenges to consider.
Like what?
Achieving perfect symmetry, managing scarring, ensuring the long-term durability of the reconstruction.
You're absolutely right. It's not a one-size-fits-all approach.
Nope.
Every patient's anatomy is unique, and their desired outcomes vary. It takes real skill and experience to navigate those complexities and achieve the best possible results.
It truly is both an art and a science.
Couldn't agree more.
Hmm.
So as we wrap up this part of our deep dive, what are some of the key takeaways you hope our listeners are absorbing?
Well, I think first and foremost, I want them to really understand the incredible diversity of these conditions.
Yeah, we've covered a lot of ground, haven't we?
We have, from relatively minor issues like polythelia to more complex deformities like tuberous breast.
And as we've discussed, each requires a tailored approach.
No cookie-cutter solutions here.
Nope. We have to carefully evaluate each patient's individual needs and goals, considering their anatomy, age, overall health, personal desires.
It's about finding the perfect solution for that specific individual.
Exactly. And just as important is understanding that although these conditions can present significant challenges, effective treatments are available.
There is hope.
Absolutely. The field has advanced tremendously in terms of surgical techniques, and ongoing research and innovation promise even better outcomes in the future.
That's reassuring to hear for both patients and practitioners alike.
Absolutely. And finally, I want to stress the critical importance of open and honest communication between patients and their healthcare providers.
Couldn't agree more.
These are sensitive issues, with a potential for profound impact on a person's self-esteem and quality of life.
It's not just about the physical aspects.
Right. It's about the emotional and psychological well-being of the patient as well.
So we need to create a safe and supportive environment for these conversations.
Exactly. Where patients feel empowered to voice their concerns and openly explore their options.
And that requires clear communication, empathy, a genuine willingness to answer their questions honestly and completely.
It's about building a strong partnership based on trust and mutual respect.
Sometimes that means admitting we don't have all the answers.
It does, but being willing to seek them out together.
Exactly. We're all in this together.
We are, and we don't have all the answers, and that's perfectly okay.
Yeah, I think it's important to acknowledge that.
The key is acknowledging our limitations, seeking out additional expertise when needed, and never stopping our pursuit of knowledge.
Lifelong learning.
Exactly. This field is always evolving, and we need to evolve with it.
Well said. Now, before we move on to our final part, let's take a moment to reflect on everything we've discussed so far.
It's certainly a lot to take in, but it's crucial information for any medical professional working with patients who have congenital breast deformities. And remember, there's a wealth of resources available for both patients and medical professionals.
Absolutely.
I encourage everyone to utilize those resources to find information, support, and guidance whenever needed.
Knowledge is power.
It is.
And in this case, it has the potential to empower us to make informed decisions and advocate for the best possible care for ourselves or our patients. Welcome back, everyone, to the final part of our deep dive into congenital breast deformities. We've covered a lot of ground.
We have, from embryology and anatomy all the way to surgical considerations.
It's amazing how much there is to know about this one topic.
It really is, and we've
Yeah.
only just scratched the surface.
Definitely. One thing that has really stood out to me throughout this deep dive is the importance of a holistic approach.
Oh, absolutely. We can't just focus on the physical deformity.
Right. It's about the whole person.
Exactly. Their emotional well-being, their body image, their cultural background, family dynamics, all of these things factor into their experience.
And how they cope with these conditions.
Absolutely. We need to really see the individual in front of us.
So actively involving the patient in every step of the decision-making process is crucial.
Couldn't agree more. It's their body, their life.
We're there to guide them, to support them.
Exactly. We need to listen to their concerns, understand their goals, and help them make informed choices that align with their values.
It's not about dictating a treatment plan,
No, it's about shared decision-making.
and that requires open communication,
Definitely. And a lot of empathy.
a willingness to answer their questions honestly and thoroughly.
And sometimes that means saying, I don't know, but let's find out together.
I think that's so important to be able to admit when you don't have all the answers.
It is. The key is acknowledging our limitations, seeking out additional expertise when needed, and committing to lifelong learning in this field.
Absolutely. Because this field is constantly evolving.
It is. Every day there's something new to learn.
Speaking of learning, are there any specific areas of research or innovation that you're particularly excited about in this field?
Ooh, so many. But I'm really intrigued by the potential of 3D imaging and modeling.
Oh, yeah, I've heard about that. What do you think the applications could be for congenital breast deformities?
Well, imagine being able to create a virtual replica of the patient's chest wall and breast tissue.
So we could essentially plan and rehearse the entire surgery in a virtual environment.
Exactly. We could optimize implant placement, minimize scarring, even predict how the tissues will behave over time.
That's incredible. It could really change the way we approach these complex reconstructions.
I think so. And what about the role of genetics?
We touched on that earlier, but it seems like we're just starting to understand the genetic basis of these deformities.
We are, but as we identify more genes involved in breast development, we'll be able to offer more comprehensive genetic counseling to families.
And potentially develop targeted therapies to address the underlying genetic causes.
That's the hope. And of course, we can't forget about the psychological impact of these conditions.
Absolutely. Living with a congenital breast deformity can be incredibly challenging.
It can, especially for young girls and women.
It affects their body image, their self-esteem, their relationships.
It can affect every aspect of their lives.
So addressing those psychological needs is just as important as addressing the physical ones.
Couldn't agree more. We need to provide access to mental health professionals who specialize in body image issues and offer ongoing support throughout their journey.
Because it's a journey.
It is. And it's one we need to walk alongside our patients with compassion and understanding.
Well said. I think that's a perfect note to end on. Congenital breast deformities are complex conditions that require a comprehensive and compassionate approach
Absolutely. We need to address both the physical and psychological needs of the patient.
to truly provide holistic care.
Exactly. Well, it's been a pleasure joining you on this deep dive today.
Likewise. And to our listeners, thank you for joining us on this fascinating journey into the world of congenital breast deformities. We hope you found it informative, engaging, thought-provoking.
I hope you learned something new.
Remember, this is a dynamic and ever-evolving field, so stay curious, stay informed, and stay engaged in the conversation.
Keep those brains buzzing.
Until next time.